Hi guys, welcome to Silent Learning. Welcome to the very first subject-specific video. Now, a lot of students have suggested that I start off with nuclear medicine because I know it's a bit technical and whatnot. So today's topic will be about thyroid gland imaging. So using nuclear medicine to work out certain disorders like cancer and different types of thyroid conditions, goiter, and how we can use certain radiopharmaceuticals, certain substances to tell us what's going on. So essentially, before I begin, I really want to touch on the thyroid gland specifically, like in terms of normal function. So the thyroid gland is located between C5 and C7, so just below the sort of Adam's apple. It has two main lobes, right and left. In the middle, you've got the isthmus, and depending on the population and depending on the proportions, you can either have a horseshoe-shaped thyroid gland or a butterfly-shaped thyroid gland. In terms of the regulation, so it starts all the way in the hypothalamus, which is the thyroid releasing hormone. That will then activate the thyroid stimulating hormone in the pituitary gland. Then the TSH, thyroid stimulating hormone, will then go to thyroid gland, activate T3, T4, and it will give the following effects. So basically, the effects are generally sort of stress related. So things like increasing metabolism, activating more of the cardiovascular system, increasing your heart rate, temperature regulation. So it's a generally sort of stress hormone. So always keep that in mind when I'm going to talk about more in detail about what you can sort of expect, what's going on when we're using nuclear medicine, because it always goes back down to the bigger picture about what the thyroid gland is actually, how is it functioning basically compared to its normal state. So we've essentially got two main radiopharmaceuticals, which are basically the substances that you take, that the patient takes, for example, into their body, and then we can then track it using several like cameras, gamma cameras, and then we can track sort of the uptake, so how much of that pharmaceutical is taking in compared to the normal tissue. So we can either use 131 iodine, or we can use 99 technetium. So why would we use one or the other? So depending on what we're looking at. So essentially with normal sort of hypothyroidism, normal, just more to see how it's sort of normally functioning, we would use 99 technetium and a specific type of 99 technetium called pertechnetate. So there's several variants of technetium, but in this case, in the thyroid, we would want to use 99 technetium pertechnetate. In terms of cancer, and looking for several types of cancer, we would rather use 131 iodine. What's the difference between that and the 99 technetium? Well, 131 iodine has a longer half-life and requires more energy, so more keV units. So it's a very energetic sort of radiopharmaceutical. So what that means is the radiation burden is higher. That just means that it gives more radiation off to the patient compared to 99 technetium. So in normal conditions, we want to keep it sort of safe. So we use 99 technetium because it's a low radiation burden, its half-life is lower, and it undergoes gamma radiation, whereas 131 iodine undergoes gamma and beta radiation. So why is that sort of relevant? Well, because if it has a higher half-life, a longer half-life, we can actually use it for therapy. So not only just imaging and diagnosing what's going on, we can actually use it to kill certain types of cancer. We can even use the fact that it has gamma and beta to aid in sort of destroying certain types of tissue. So that's why we'd use 131 iodine over 99 technetium in certain conditions. We can also use 123 iodine, and that can only do gamma radiation only, and it has a shorter half-life and it's cheap and whatnot. But for the sake of cancer diagnostics and therapy, we want to stick to 131 iodine. So in terms of the normal imaging of a thyroid gland and hyper and hypothyroidism, first we should look at where the thyroid gland is in the first place. So using 99 technetium pertechnetate, which is the standard now for working out hypo and hypothyroidism and goiter, the first step should be, where is it specifically? So obviously I told you at the start, we expect the thyroid gland to be between C5 and C7, but in some conditions you can even have something called ectopy, which basically means it's not in the place that we expect it to be. So not below the Adam's apple, we can even have it behind the sternum. So this is called retrosternal. We can even have sublingual goiter, so where the uptake is found sort of just beneath the tongue, and we don't really expect that within the thyroid gland. So that's something to sort of keep your eyes open about. And we can even have ovary, so within the ovary. So that's really weird. It's mad how all the iodine uptake and the thyroid gland functioning happens here, but then you can also find it down in the ovary. So that's another alarming sign. In terms of its function, so normally when we're imaging the thyroid gland, we expect something called homogeneous uptake, which means the uptake in the right lobe is equal to the one in the left lobe, and that's normal, right? It means everything's going well, everyone's doing their job. But in hyperthyroidism, so in things like Graves' disease, we expect one lobe to have more uptake than the other. Or for example, in hypothyroidism, we'd expect one lobe or even both lobes or whatever to have significantly lower uptake of the radiopharmaceutical. That means it's not doing its job compared to the normal tissue. And the magic number that we want to be looking at in thyroid gland imaging and uptake is 4%. So anything above 4% is an issue. Anything significantly below 4%, like 0 point something, for example, is hypothyroidism. Yeah. So just touching on as well about TSH. I mentioned before TSH is the main hormone which will activate T3, T4. This is really important because TSH is actually the significant marker in which we can distinguish several types of diseases and cancers from each other, because TSH is sort of basically the whole shebang. It basically gives you information about everything, how it binds into receptor, how it allows increased uptake of iodine. So we don't measure TRH or measure T3, T4. We would measure T3, T4, but the main sort of diagnostic marker is TSH. So always remember that TSH will give you complete info, and that's why we want to look at that as a sort of lab test, marker. So that was the normal function. Now I'm going to get into sort of the cancer kind of sort of idea. And cancer is what we should be studying more when it comes to nuclear medicine. So when it's nuclear medicine imaging, we tend to look at oncology more than normal things. Yeah. So with cancer, we have sort of 3 progressions. We can either have a cyst, which can then progress to potentially a tumor, either malignant or benign, and then we can have a full-fledged cancer. So we can have several types of so-called hot spots or cold spots, depending on what's going on. So for example, in a cold nodule, this means that the radiopharmaceutical is being uptaken less in the maybe like the cancer or whatever, like the bad tissue, compared to the thyroid gland. So that's showing you that there's less function going on in that sort of damaged tissue. So for example, in a cyst just basically means that tissue's been sort of destroyed and messed up. So obviously, logically, it's not going to be able to uptake that radiopharmaceutical that the patient inhaled from the beginning, whereas the rest of the thyroid tissue will show normal functioning. So you'll get like a so-called cold nodule or cold spot compared to the rest. So now you can work out that it's something's going wrong. It's potentially a cyst. So then with a tumor, we can either have malignant or benign. Malignant basically means the cancer cell has basically degenerated and become dysfunctional. And you find this in 15% of cases. 15% of the time in cold nodules, it's likely to be a malignant tumor. So you have decreased function compared to the rest of the thyroid gland, and that's why you get these cold spots. Then you have cancer or full-fledged cancer. This is when you have 2 types of cancer, so differentiated and non-differentiated. Differentiated just means the cancer cells are equivalent to the normal cells and they behave in the same way, whereas non-differentiated thyroid cancer basically means the cancer is nowhere near like the thyroid, like the normal thyroid cells, and it just does its own thing, and it's really hard to sort of help diagnose that and manage that. So with differentiated thyroid cancer, the cancer sort of works like the normal cell, but less so. So then you could still find cold spots. So hopefully that makes sense. And in terms of hot nodules, so this is where it's the complete opposite. This is where that damaged tissue or whatever is acting way more actively than the normal sort of thyroid cells are. So that you get the opposite. You get hot spots. So the uptake is way higher in that specific tissue compared to the rest. And it's things in like benign cancer where, for example, the benign cells, benign cancer tumor cells, whatever, they have increased activity. So they're produce lots of T3, T4, and in response, you get less TSH because the TSH doesn't want to regulate everything, and it doesn't want too much T3, T4. So as a result, because there's less TSH, that means there's less thyroid activity going on for the other normal cells, so they get less T3, T4 compared to the cancer cells or whatever. So basically, the other bad cells are doing all the work. They're taking out everything. They're being selfish basically, and then other thyroid cells are like, what the hell? Like, where's my thyroid and T3 and T4? So we have three types of nodules, hot nodules. We have compensated, subcompensated, and decompensated. So basically, in compensated, in certain tumors, for example, this is where the damaged tissue is uptaking more of that pharmaceutical, the radiopharmaceutical, compared to the rest of the tissue. So you get traces of thyroid tissue hanging around. Subcompensate is even a more aggressive form of that, where the cancer or the whatever is eating more and more of that radiopharmaceutical. Its activity and function is so high, so you get even less thyroid normal tissue around. And then decompensate is when it's significantly really bad, when it's eating up everything and it's literally just one basically mass of a gland eating out everything. So that's decompensated, and there's literally no other thyroid tissues sort of normally functioning there, and that's basically, you see that in toxic goiter. So that is like really like a red flag. I also want to talk about non-differentiated cancer. So I said before, non-differentiated cancer is when the cancer cell is nowhere near like the normal. So how do we distinguish what is normal from the cancer cells? Well, we can use a specific type of radiopharmaceutical called 99 technetium MIBI. I don't know what it stands for, but all I know is it's a very tumor-specific radiopharmaceutical. So it only recognizes the cancerous cells more than the other normal cells. So it only sees malignant sort of tissue. So when you see the scan, you see the results, you'll see hot spots for the cancerous part and cold spots for the normal part. So this will tell you that there's a tumor going on. And specifically back to differentiated thyroid cancer, we can even use 131 iodine for, like I said at the beginning, not just diagnostics but therapy as well. So usually when patients have a severe form of the cancer, they're likely to get thyroidectomy, so removing of the thyroid gland, and we'll then undergo something called whole body diagnostics. So this is when we measure the whole body and see where the rest of the uptake is happening from this radiopharmaceutical. And because cancer is likely to do metastasis and move to other parts in the body, we'll do a whole body imaging technique, and we'll find out where these other hot spots are within the body. Once we found out where the metastasis is, we can do something called ablation. Ablation just means absolutely destroying those specific metastasis, blobs and hotspots throughout your body. And we can use iodine 131 at a higher dose to kill off those metastasis or hot points. So that's how you get rid of the cancer. If we want to get rid of the cancer completely, we do something called ablation, where we use a higher dose of 131 iodine. Just extra points as well. I forgot to mention warm nodule. So this is just essentially between cold and hot. So the uptake in the bad tissue is sort of similar to the normal tissue uptake. So this kind of tells you that the cancer, or maybe a benign adenoma, is acting in the same sort of way, similarly to a cancer cell, to a normal cell, and that can be sort of very, very hard for the doctor to work out what's going on. Back to the 99 technetium per technete, I also forgot to mention that instead of nodules, like you see in cancer, instead of nodules, we have something called diffuse goiter. So this is when you see a whole patch of either hot areas or cold areas, depending on what you have. So this is going back to the fact about hypothyroidism having less sort of uptake and Graves having lots of uptake. So you see a whole big hot patch compared to the rest of the tissue. And yeah, that was it, guys, and hopefully that benefited you guys. Thank you very much.